Everyone. So I will present this talk on transition to adult care for children with liver disease and after liver transplantation. So I have no conflict to disclose, but this presentation is just to prime this audience about the need for transition clinic at our institute. So in view of limited time, I will just rush through and skip some of the slides, but the overview will be why, how, when and where to transition these children. So just I will take you through some of the scenarios which we encountered. So this is 19-year-old boy, biliary atresia post-Kasai, who underwent Kasai at 73 days of age. So subsequently, by 18 years of age, he presented with itching, jaundice, clay stools, and subsequently he presented with hepatosplenomegaly. So he had liver, spleen, so bilirubin was 16.9, platelets were normal. So we thought of whether this is just like a natural course of biliary atresia and now he is going towards decompensation, or is this just cholangitis, is this a delayed presentation of a cholangitis, or if this or is this cholestasis precipitated by virus or drug, or are we dealing with some separate intrahepatic cholestatic disorder. So ultrasound showed increased periportal echogenicity, CT showed smooth outlines, but there was portal hypertension, dilated portal vein. And so these are the ultrasound and CT pictures. So MRCP was done, which showed beading pattern in the bile ducts, and there was cholangitis. So subsequently biopsy was done, which showed evidence of Esner disarray, cholestasis. So he was started on IV antibiotics and then subsequently cyclic antibiotics. Bilirubin resolved over a period of few weeks to months. So this was normal. So then later on he presented at around 26 years of age, normal bilirubin, normal platelets, and just with mild slightly high transaminases. So this time evolution, again you can see here, there in MRCP there was bleeding and irregularity was slightly worsened from the previous MRCP, but still at this age he does not merit a liver transplantation. So second scenario is, so this was a child, 17-year-old from Indonesia, who had a Kasai portal enterostomy at 47 days of life, who had portal hypertension. When he presented large varices, then he came to us with fever and jaundice with hepatosplenomegaly. So here in this case, spleen was very big. So his issues were portal hypertension, high MELD, and evidence of portal hypertension and high fibroscan. So when he came to us, his bilirubin was 19, his BMI was low, so and MRCP showed multiple beading patterns, so almost a picture which is similar to primary sclerosing cholangitis and with hepatolithiasis. So we gave him IV antibiotics for a period of 6 weeks. His bilirubin came down to 7.6, but when we analyzed that he was fulfilling most of the indications for liver transplantation: high MELD, refractory cholangitis, hepatolithiasis, portal hypertension. So he underwent liver transplantation at our institute. So long-term survival of post-Kasai after in biliary atresia is said to be around 20 to 30%, and most of them have portal hypertension, cirrhosis. Some of them may have hepatolithiasis, and this is predicted by bile flow at the time of Kasai. So this is a study where they mentioned that the liver transplantation in adulthood is required in around 17% of the children, and most of them have issues related to cirrhosis and portal hypertension. With related to pregnancies, 21 of the females were pregnant, and they gave 30 live births also. So as Sir has said that biliary atresia is almost similar to primary sclerosing cholangitis. So this study from King's have looked up the Mayo PSC score, which helped in predicting the survival of with native liver in biliary atresia. And biliary atresia children may also develop liver cancer around 1.3%. So these are the various issues which may sprout up by adolescence or adult age in children with biliary atresia. What about Wilson? So this is another scenario, 25-year-old male, so who was in our follow-up since for last almost 13 years, when he had decompensation, portal hypertension, high HVPG with chelation, everything resolved. So he compensated, he was on D-penicillamine and zinc, but he had issues related to depression, anxiety, gynecomastia. So his issues were poor adherence to medications, portal hypertension, gynecomastia, and certain mental psychiatric issues. So next scenario is again a transplant for Wilson disease in 2011, who had recurrent episodes of rejection, and these episodes were related to poor adherence to medical visits and also to medications. So we can see here, so he had persistently high transaminases, which were managed by increase in the immunosuppression dosage as well as the number of immunosuppressants which he received. So he had multiple episodes of late acute rejection. So now coming to why to transition. So children with liver disease, so number of children who are growing into adults are increasing. They have improved survival, better transplant outcomes, but when they reach adolescent or young adult life, they have high risk of mortality, high risk of graft loss, and substance misuse, and also suicide. So key to transition is developmentally appropriate care for these young adults. Also, they have poor adherence, and apart from adherence, they have other issues related to the graft, or related to self-management, independence, education, career, job, social life, identity, partners, risk behaviors like related to sex, drugs, alcohol, smoking, suicides. So these are studies on education and employment in biliary atresia when they grow adults. So it is mentioned that around 55 to 88% are employed, but remaining may remain unemployed. So this is a systematic review where they mentioned that they have lower social functioning scores, and some of them may require additional educational support, and around 60 to 100% were employed, but a proportion may remain unemployed. So what about the other endocrinal issues? 6% may be amenorrheic, and so which is related to the causes as in other cirrhotics. What about pregnancies in females with biliary atresia? So so it is mentioned that 35% may have menstrual problems, and also the 16 of the females in this particular study from Japan, they mentioned that they had 23 deliveries, 2 abortions, but there were issues related to pregnancy: abruptio, massive variceal bleed, fetal distress, abortions, and deranged liver functions. So 6 of them had liver dysfunction after delivery, requiring liver transplant. So this is another study again from Japan where they mentioned that of the 47 patients who were older than 20 years, 57% had stable LFT throughout, and 13% had totally uneventful course, and 11% had relatively uneventful course. But of these two groups, a proportion decompensated, and this decompensation episodes were triggered by hard labor or pregnancy. So whether they should be allowed to do hard work or to allow to become pregnant. So 8 of the pregnancies in these 6 patients, 2 had liver decompensation requiring liver transplantation in the postpartum period, and 1 of the patient delivered 2 babies after liver transplant. Health related quality of life, they have poor functioning, poor scores in terms of emotional and psychosocial functioning, and it was mentioned that high bilirubin and black race was associated with the poor health related quality of life. What about Wilson disease? So this is a study from King's College in 74 children who were followed up to a median of 10 years, and their median age at the time of last follow-up was 22 years. And at the last follow-up, around 86% survived. There were 10 deaths. So important thing to note is 6 died after liver transplantation in the long-term follow-up. 7 had graft loss, and there were mental health difficulties and non-adherence to medications in half of them, neurological issues in around 1/3, cognitive difficulties also, autism, and it is mentioned that when they were managed in multidisciplinary clinic, so they had better documentation of these health issues, and they had less graft loss, 6% versus 20%. So this is just an idea about what are the numbers of transition patients who are happening in UK. In a 6-year period from 2008 to 2014, around 620 patients were eligible for transplant, 16 to 17 years of age, and of the post-transplant patients, around 750 patients were transitioned to the adult side between 2008 to 14. So what are the challenges? At the pediatric level, as pediatrician, we have challenges that we are more emotionally attached to the patient and the family over years. So we say that how can we let the patient go from our side? And from the adult side, they have busy clinics, less time, less concerns for growth, metabolic issues, peer pressure, psychosocial issues, and also monetary and employment issues. So the adult side say we don't have time, but we'll somehow manage to see the patient. So transition is not synonymous with transfer. Transfer is just change in location and change in healthcare providers. But transition is a purposeful planned process of moving adolescents and young adults with chronic medical and physical conditions from a child center to an adult-oriented healthcare center. So this is an important milestone for patients, families, to both adult and pediatric side, and to the health services. And this is an important period of vulnerability for the individual patient. So 4 randomized control trials, not just in liver, but overall related to other diseases also, they mentioned that when interventions are done related to the transition, so these interventions lead to better transition readiness, better self-management, adjustment, and knowledge of the disease. But there was no improvement in health-related quality of life or well-being. So if there is inadequate transition, this can lead to delayed and inappropriate care, poor communication with patient and families, and emotional and financial stress for patients. And if there is poor transition after organ transplantation, so then this can lead to worsening adherence, increased graft loss, and higher mortality. So this is a study from US. 236 transplant hepatologists were surveyed, and they mentioned that 46% of the patients who attended their first adult clinic visit arrived with full knowledge. So around 54% did not have any knowledge of their disease, or their parents did not have any adequate knowledge of the disease. And there were different barriers which were perceived at the level of the provider, patient, or related to the process. So this is another study from Emory, Atlanta, where they mentioned that before a formal transition program, around 30% of the patients may die if they are not properly transitioned. And so again, this study again mentioned that black race, substance use, diabetes, or failure to graduate high school before transfer lead to higher mortality after transfer to adult healthcare. Also, another factor which was associated or univariate analysis was tacrolimus level medication level variability index. That is a standard deviation of last 3 to 5 tacrolimus levels. So if this standard deviation is high, so that means that there is more fluctuation in the tacrolimus levels. So the patient may skip the medications and may voluntarily take a higher dose just before coming to the clinic. This leads to higher standard deviation in the tacrolimus levels. And if these levels are high, more than 2.5, this is associated with graft loss and also mortality. What about cognitive issues? So there are, post-transplant, the children may have below average intellectual functioning, math weaknesses, executive functioning, and they may require special education. And their IQ is related to household status, parent education, weight Z-score, and also transfusion volume at the time of liver transplant. So post liver transplant, children more likely to have mental health conditions. Around 18% may have anxiety or depression, and this is attributed to fatigue, sleep difficulties, or problems at work, school, or and to low self-esteem. Substance use is almost similar or lower than the healthy peers, and this affects the transplant eligibility and leads to poor outcomes. What about health literacy, knowing about the disease, or health education? So it has been found that limited health literacy in 57% of the patients and 47% of the caregivers, and this was related to, so better health literacy, so poor health literacy was associated with younger age and lesser education status, and higher health literacy was associated with higher transition readiness. And one of the factors which was associated with higher patient health literacy was caregiver education status. So various barriers have been identified to successful transition, as in this study. These may be at the patient level, provider level, or at the system levels. So this chart mentioned that what are the various levels. Like it may be at the adult provider level, related to reluctance to take the patient in, or there is discomfort to take the care of childhood onset chronic conditions, limited time, busy practice. Then at the pediatric provider level, there may be reluctance to transfer or fail to assess the transition readiness. Then it may be at the patient level, that is the young adult level, there may be executive dysfunction, neurocognitive or psychiatric conditions, or limited health literacy. This may be related to the allograft, when there is graft dysfunction, inadequate immunosuppression, or complications of immunosuppression. Or it may be at the system level, when there is inadequate staff to look after the transition, time constraints, or lack of the mental health care services. And also there may be other social factors which may be the barriers to successful transition. What about adherence? So adherence is an important barrier. So what are the various reasons for non-adherence? These again may be related to socioeconomic factors, patient, disease-related or treatment-related factors. Now, how to transition? So three major integral categories of transition are to build and support self-management, engagement with the receiving team, and guidance of patient and families. So these are the 6 core elements of transition. First, to have a transition policy guide, track and monitor and list the patients who are actually for transition, and then orient them into the adult practice and integrate them into the adult practice, and followed by first visit and ongoing care, and reassess whether the patient and the providers are comfortable with the transition. So this is a document published last year from ASLD, that how should actually we take care of these patients who are for transition. So these are the various core elements. I will just skip this. So this chart mentions that early transition phase is 12 to 14 years. Middle transition is 14 to 18 years, and late transition is around 18 to 25, or some people say 18 to up to 30 years. So we should have a transition policy, develop tracking record, and list down the patients, and also conduct regular transition readiness. And those who are not transition ready, make them transition ready by having skill building activities and educational activities, by providing them education about their disease, and establish plan with target rates for transfer, and then have a proper visit with the adult team, and then confirm the first appointment, and subsequently have feedbacks about that appointment, if the patient, the pediatric team as well as the adult team, they are happy with the transition. So again, this is a French model, almost same. To have a policy, readiness, joint consultation, transfer, and feedback. An important point is that the pediatric, like in the previous one, that the pediatric team acts as the consultant whenever there is need. So or it may be so there should be a joint consultation, but the pediatric team should be given that opportunity, that they should act as a consultant whenever it is required. So how to reduce the non-attendance rates? So this is a study from King's, where they use telephonic interviews to decrease the non-attendance rates from 25 to 8%. When to transition? As I already mentioned, that a proper age is around 12 to 14 years, and these issues should be resolved. The patient should have normal growth. She should be in the later stage of puberty. There should be compliance to follow-up and medications, and the patient should be transition ready. He should have adequate knowledge about the disease, and also the graft function should be normal with a stable level of immunosuppression. So it should start by 10 to 14 years of age, and the child or adolescent should swap role with the parents. So he should have active role in decision making, and attending clinics, taking medications, and maintaining a healthy lifestyle. And this timing should be individualized based on physical development, psychosocial, education, and emotional needs of the patient. And most important is the patient should be clinically stable. And how to assess the transition readiness? So various questionnaires are there. The most common is the TRACK questionnaire, which includes various aspects related to underlying medical knowledge, and also the self-management skills. So this is a simple questionnaire which should be used to assess for the transition readiness. This is about executive functioning. To understand this, I would like to take suggestion from Dr. Mohit, because he will know this better. So executive functioning is said to be mentioned. It directly relates to the transition readiness in both the domains related to metacognitive and behavioral regulation. So what about self-management? So self-management is, we say that the patient can manage his medications or his health on his own when he's able to contact his or her healthcare team. He knows when and how to access the emergency healthcare services, can create his history, and also is able to maintain a healthcare record, and is able to communicate with healthcare providers, is able to describe his medications. So how can we assess self-management, if the patient is able to manage him on his own or not? So this is a score which is responsibility and familiarity with illness survey Riffles score, based on various aspects. And when this Riffles score was used in this US study, it was found that for patient as well as for the parents, these Riffles score were almost similar, but these Riffles score predicted non-adherence and rejection, and these score correlated with medication level variability index. So where to transition? So one proposed model is a joint transition clinic, and other thing can be, it can be at an adult healthcare center or OPD to allow the pediatric patient and the pediatric consultant to be there, and so that the pediatric patient become more familiar with the new setting. And there is also a proposal, there should be a transition specialist or coordinator who facilitates the smooth transition of the care, and communication between the teams is very crucial. So transition is a holistic process, so it should include, apart from the patient is at the center, but it should include various teams: adult hepatology, pediatric hepatology, social worker, psychiatrist, psychologist, nutritionist, pharmacist, and a transplant coordinator, as well as a transition coordinator if possible. Apart from that, the extended team members may be a metabolic expert, patient mentor, peer support groups, and other volunteers. So there are various specific issues which have to be addressed in an adolescent and young adults, and this is the list. Like, we should look for the adherence, self-management skills, healthy lifestyle, reproductive health, risk-taking behaviors, school, employment, insurance, psychosocial health, and also the introduction to the adult care and the new providers. How to assess substance use and psychosocial health. Various questionnaires are there, like S2BI, BSTED, and also for the psychosocial health, this is a score. This is a questionnaire which is HEAD SSS score, which takes into account the home, education, employment, eating, exercise, activities, hobbies, peer relationships, drugs, sexuality, gender identity, suicide, self-harm, depression. So this is a composite score which takes into account everything. So how to deal with non-adherence? So non-adherence to medications, so that is common in the adolescents, and this can be checked by monitoring, by using various questionnaire, and also by using pill bottles, refills, and also the drug levels, which I already mentioned, that is medication level variability index, which is the standard deviation of last 3 to 5 tacrolimus levels. So this is a study which was done from our department. 152 children, Wilson, autoimmune and post-liver transplant, and it was found that around 12 to 16% had either missed doses or late dose non-adherence, and this was related to older age. So again, in adolescents it was more common, rural place of stay, and also related to medications. And how to deal with non-adherence? So this can be dealt with by efforts of social workers, or and by peer support groups, regular review of medications, and also by weekly multidisciplinary meetings. So the patient passport is another aspect. So this is a healthcare passport which has been used by various teams. So this takes into account individuals' medical history, past procedures, medications, allergies, any disabilities, and specific healthcare difficulties. So these use of these passports further empower the young adult and is an important educational opportunity. So this is a sample of a health passport which is used by NHS at UK. So lastly, we should assess the outcome of a good transition program. So outcome should be assessed in terms of medical outcomes like patient and the graft survival, and the complications of immunosuppression, adherence in terms of the MLVI, and also the follow-up visits, healthcare utilization in terms of the emergency visits, hospitalization and length of stay, health-related quality of life in terms of questionnaires, and retransplantation rate. So finally, to summarize, I can say that transition should be a gradual process from adolescence to adult life, which should take into account all the aspects related to the graft, immunosuppression, growth, education, psychosocial development, sexual development, employment, and also self-management and independence. Thank you.